A 24-year-old male presents to urgent care with dark urine, fatigue, and new onset jaundice. He reports feeling well until 2 days ago, when he developed fever and was started on trimethoprim sulfamethoxazole, which is TMP-SMX or Bactrim, for a urinary tract infection. Within 48 hours, he noticed increasing fatigue, yellowing of his eyes, and his urine turning tea-colored. He denies abdominal pain, but feels short of breath with minimal exertion. His past medical history is none. He's got no chronic medical conditions. He takes no daily medications. His mother did mention that he had some quote-unquote blood problems on her father's side, denies alcohol or recreational drug use, and there's been no recent travel. On physical exam, the patient appears tired and icteric. He's got scleral icterus present. He's got a pale conjunctiva. He is mild tachycardic. He's got no splenomegaly, the lungs are clear, and no abdominal tenderness. His vitals consist of a heart rate of 112, a blood pressure of 122/78. He's breathing about 18 breaths per minute. His temperature is 98.7 Fahrenheit, and he is satting 99% on room air. His labs show a hemoglobin of 8.1 grams per deciliter, where he usually has a baseline of 14 grams per deciliter. His reticulocyte count is elevated. His LDH is elevated. His haptoglobin is low. His indirect bilirubin is elevated. The urinalysis is positive for hemoglobin, but no red blood cells. And the peripheral smear shows bite cells and Heinz bodies. Here's what the peripheral smear looks like. So what could cause this sudden oxidative stress leading to hemolysis after starting Bactrim? The correct diagnosis is G6PD deficiency, which is an X-linked recessive condition causing the red blood cells to become vulnerable to oxidative damage. The pathophysiology of G6PD is quite interesting. In G6PD deficiency, the red blood cells cannot regenerate NADPH. Without this NADPH molecule, they can't neutralize oxidative stress. Because of the oxidative stress being unneutralized and running rampant, the hemoglobin denatures and starts to break down. And this breakdown of the hemoglobin produces Heinz bodies. As these red blood cells travel in the blood to the liver macrophages remove them from circulation by biting them out. This produces the bite cells and leads to hemolysis. It's quite fascinating. Because you have hemolysis, you have a rise in indirect or unconjugated bilirubin, because the red blood cells are being destroyed faster than the body can clear their breakdown products. When the red blood cells rupture, the hemoglobin is released into the bloodstream and processed by the macrophages into heme, then biliverdin, and finally indirect bilirubin. Under normal conditions, the liver conjugates this bilirubin so that it can be excreted. That's the whole point of conjugation. How do I make it more water soluble so I can get rid of it? As a result, indirect bilirubin accumulates in the blood and produces the jaundice and the scleral icterus. The tea-colored urine seen in hemolytic episodes occurs for two reasons. First, this massive amount of free hemoglobin that's released during the hemolysis saturates haptoglobin, leaving excess unbound hemoglobin circulating in the blood. This unbound hemoglobin gets filtered by the kidneys and spills into the urine, causing hemoglobinuria, which gives urine a dark tea-colored appearance. Second, the increased bilirubin production also leads to increased urobilinogen, some of which is reabsorbed and excreted by the kidneys, further deepening the urine color. Combined, these processes, the classic cola or tea-colored urine associated with acute hemolysis. So what are these triggers of G6PD? What are these oxidative stress triggers of G6PD? Common triggers include sulfa drugs, things like Bactrim, antimalarials, nitrofurantoin, the famous favavines, severe infections, and high doses of aspirin. I remember it using the mnemonic SNAP fever. The treatment focuses on stopping the offending agent. In our example here, stop the Bactrim. Hydrate them well with IV fluids, give them oxygen if needed, and if the anemia is severe enough, transfuse them. But honestly, most patients recover once the trigger is removed. A patient who develops jaundice, dark urine, and sudden anemia after a trigger, especially a sulfa drug, should immediately make you think of G6PD deficiency. And remember, the exam loves the combo of bite cells, Heinz bodies, and a trigger. And until proven otherwise, that's G6PD.